Okay, so we're gonna start where we left it before, right? So as we were talking about the pathological causes of hyperprolactinemia, we covered the pituitary hypothalamic disorders, but there are other reasons that can lead to hyperprolactinemia, such as primary hypothyroidism, right? As you remember from the lecture, the thyroid is releasing hormone can stimulate the also the prolactin, which means that basically it can affect prolactin. Also, other medical conditions such as seizures, polycystic ovary disease, very important, neurogenic causes, chest wall trauma and surgery, herpes, renal insufficiency, cirrhosis, and pseudocyesis, which is false pregnancy. All these can lead to increase of prolactin, or also known as hyperprolactinemia. So after the lecture, if you have any doubts, we have an ID meeting, which I will cover some of the doubts after the lecture for 1 hour on the computer in a VOOP meeting. So this is the ID number for those that need, but also Nancy, I think that has sent a message in all the students in the group. So how about the epidemiology of hyperprolactinemia? If you guys want, there is a very nice paper talking about hyperprolactinemia. So there was a study based on a population retrospective follow-up of 400,000, and they identified patients had serum prolactin assay, 32,000 patients, right? And that from this over 32,000 patients, 1,300 had hyperprolactinemia. So it's more common than what we actually think. If we look at this graph represents per 100,000 person per year, and we can see females in black, male in gray. And what you can see, obviously, looking at the general population, there is an increase of prolactin in females, obviously at the age of reproduction age, 25 to 34, 35 to 44. This is probably mainly to reproduction activity, but still it's much higher compared to men after in later stages. And then it's similar between men and females. So if we look further into the epidemiology of and presentation of hyperprolactinemia, if 20% of the cases have a pituitary disorder, right? This study is actually very, in clinical endocrinology, very good study if you want further interest in the subject. 46% of the patient had drug-induced prolactin, so that's quite a lot, right? And remember, antipsychotic, antidepressants, and other drugs can affect prolactinemia levels. 7.6% have a macroprolactin, and 15% of all the cases of hyperprolactinemia, they actually had an idiopathic effect. And another 7.5% have hypothyroidism, which obviously is related to prolactin release. So again, also prolactin can be pharmacologically triggered, and we know that antihypertensive drugs, right, can increase prolactin secretion. Psychotropics such as antidepressants, right, serotonin inhibitors, receptors, and uptakes, and lots of antidepressants have an effect also on the prolactin secretion. Antipsychotics also can produce increase in prolactin, so side effect of these drugs very important. You don't need to know at this level the name of the drugs, but just know that psychotropics, antidepressants, antipsychotics can produce high levels of prolactin and hyperprolactinemia. Also, other drugs, recreational drugs, such as opiates, cocaine, also protease inhibitors, and also medicinal herbs used in traditional medicine. For example, St. John's wort, which is an antidepressant drug, purple cornflower, black cohosh, and gum arabic tree. All these are taken as an infusion, right? And they help in several different treatments, but they can produce also hyperprolactinemia. What we have in this table is antipsychotic drugs and whether they have a high or low level. Again, this is more for a specialty in endocrine, but you just need to know that some drugs have a severe effect or a secondary effect on prolactin secretion. So what are the investigation of prolactin? The initial investigation is to look at the thyroid function test. As you know from the class of the hypothalamic hormones, thyroid thyroid releasing hormone can have a activating effect on prolactin, but also what will be the second test that you will do if a female patient presents with high prolactin. The most obvious thing is to actually look at pregnancy tests because she might be pregnant, right? So pregnancy may increase the prolactin production. Basal serum of prolactin are normal of less of 400 units per liter, and mildly elevated can go from 400 to 1,000, and is if the elevation on the serum level is above 5,000, then it's usually signs of prolactinoma or a pituitary tumor. So then there require further investigations. If the levels in the serum are very elevated and you suspect that there is a pituitary tumor secreting prolactin, then that requires further investigation and normally is through MRI, magnetic resonance, of pituitary to identify whether there are microtumors, microadenoma, or macroadenomas. The macroadenomas are very severe because affect visual field tests, and they will require visual field tests, which means to see whether the vision has been affected in this patient, and also rest of anterior pituitary function test. The aims of the treatment are obviously considerable and understandable, right? Because as you may know, like I've seen all the physiological functions of this, so I could say that obviously one of the main important functions of the treatment or aims is to restore fertility and sexual function. This is very important. Stop galactorrhea. I told you what is galactorrhea. Galactorrhea is secretion of milk or production of milk outside of the pregnancy. And it can happen in women, but also it can happen in men. Restore regular menstrual periods and libido. Hyperprolactinemia makes amenorrhea, which is a stop of the periods. Therefore, if we treat the high prolactinemia, it will restore menstrual periods and libido. Estrogen, testosterone need for bone protection, so obviously regaining menstrual periods and normal level of estrogen and testosterone is very, very important for the capacity of the bone and healthy bone formation. Can you use exogenous estrogen and testosterone? contraceptive, hormone replacement therapy, and testosterone. Also, the aim of the treatment is to shrink tumors such as like microadenoma. And there are drugs that work, and these basically aim to restore anterior pituitary function and to restore vision and abnormal visual paths. The management of prolactinoma, if it's asymptomatic and very a microadenoma, there is no treatment. But the first line of treatment for the cases where there are symptoms, right, is dopamine agonist. Now, if I was in the lecture, I would say, why is dopamine agonist? I leave it open to you. But we have studied this. That's why it's very important to know the hypothalamic factors that regulate prolactin, right? So there are two drugs, cabergoline, bromocriptine, that work very well, right, in basically inhibiting the secretion of prolactin. When trying these two drugs, there is the need to exclude cardiac back fibrosis and pulmonary fibrosis before the treatment and monitor after. Side effect is excessive or sudden sleepiness, postural hypotension, and obviously when starting the treatment. Those are secondary effects of the treatment with the dopamine agonist. And just to remind you that the dopamine works through the D2 receptor and it activates cyclic CMP, has transmembrane domain, but we have looked into this into the other lectures in the prolactin secretion, if you remember lecture, right? But the dopamine works as a inhibitory effect in the hypothalamus on the secretion of prolactin in the anterior pituitary gland. So more management of prolactinoma. Microprolactinomas can take combined oral contraceptive pills, HRT, if fertility is required, can be discontinued treatment in pregnancy, and can trial withdraw of treatment after 2 years. Those are very specific clinical aspects. At your level, you just need to have a consideration. You're going to go back to it further in your medical degree if you require. Now, idiopathic hyperprolactinemia, if you need to assume that there is a microprolactinoma, right, or too small to be detected the tumor into an MRI radiologically. Now, also there is the other class of tumor, which are NFA, which are non-functioning adenomas or non-functioning pituitary adenomas. Non-functioning pituitary adenomas are the ones that basically do not secrete any hormone. So they don't have an effect on the hormonal status of the patient. And basically can compress the pituitary stalk and then stop the hypothalamic inputs into the pituitary. This connection with the pituitary stalk can cause hyperprolactinemia, may also occur with hypothalamic masses, may need surgery or radiotherapy because obviously space occupying effects of the tumor, if you think about the tumor growing inside of below the brain, there is high risk of loss of pituitary function. So concentration of prolactin will decrease dopaminergic drug and need monitor an MRI and a scan of visual fields. So now that we have touched on one type of tumor, remember we're going to be covering the other type of tumors in each specific axis, but now we're going to go into the growth hormone secretion disorders, okay? Very important. Remember one of the slides that I presented you on the first lecture of the IHP axis. Too little growth hormone gives rise to hypopituitarism, and this is one of the shortest man. So there is no growth, linear growth, pubertal growth. Now, too much growth hormone before pubertal spur or pubertal growth, right? Before the bones have fused, give rise to gigantism. So gigantism is overproduction of growth hormone from a pituitary tumor and produces the person grows to produce a giant. Underproduction gives dwarfism, and there are multiple syndromes, and we are studying the genetics. We are also studying the genetics of gigantism. So, if the tumor occurs after the growth, so once the bones have fused, this is considered as acromegaly. And the tests are oral glucose tolerance, and in the dwarfism are insulin tolerant tests, and also growth hormone deficiency. So what are the epidemiology of acromegaly? If we look at the incidence per million, the mean average is 3.3 cases per million. So they are rare diseases, but they are there. The prevalence per million is 58 in average. Age at diagnosis is 44. The duration of the symptoms prior to diagnosis is 7 to 10 years with a mean average of 8 years. And there is no bias on gender or male female. The male female preponderance is 1 to 1. So the etiology of acromegaly basically is excessive growth hormone production by the pituitary. Again, the pituitary adenomas can be microadenomas, so small tumors in the pituitary, or macroadenomas. They are also called somatotroph adenomas. In this case, they can be also mixed growth hormone and prolactin secreting. So they are called, when they are both tumors, prolactin secreted and growth hormone secreted, they are called mammosomatotroph adenomas. So basically, they produce prolactin and somatotrophs produce growth hormone, and this is a double type of pituitary adenoma. They can develop into carcinoma, which means malignancy. Extrapituitary growth hormone secretion, right, also can occur not only in the pituitary, but they can occur in hypothalamic tumors, carcinoid tumors, pancreatic islet cell tumors, small cell carcinoma lung, adrenal adenoma, and ectopic growth hormone secretion. In the case of posterior hypothalamic or hypothalamic tumors, what can happen is that there is increase on the growth hormone releasing hormone, and therefore the pituitary will produce more growth hormone. So, what are the clinical presentations of acromegaly? If the tumor occurs after puberty, there are certain areas of the body that are sensitive to growth. So the nose grows, the ears, but more importantly, the mandible. And you can see this facial appearance with progmatism of the mandible, bigger ears, bigger nose, and the hands. The hands keep growing, right? And also it presents with the teeth which are separated. These are the typical appearances of acromegaly. Acromegaly causes an overgrowth of all organ systems. like for example bones, joints, and soft tissues. But if the tumor occurs after the person has reached puberty and has already grown, does not give gigantism. Symptoms are due to excess growth hormone and increase in insulin-like growth factor 1, IGF-1. There is a gradual change in appearance, hands and feet enlargement, nose thickening, macroglossia, growth of the jaw, prognatism, coarsening of facial features. Macroglossia is enlarged of the tongue, so the tongue is enlarged in these cases because keep growing, and this can be caused obstructive as sleep apnea. So it's like when there's no oxygen and cannot breathe at night time because the tongue is too big. There is also hyperhidrosis or excessive sweating. Mild hirsutism in females. Remember, hirsutism is excessive facial growth of hair. There is also articular overgrowth of the synovial tissue, arthritis, and back pain. There is also visceral hypertrophy, heart, liver, thyroid, kidneys, and in some instances also prostate. And also there are tumor effects on the nerve compression. Very importantly, if untreated or misdiagnosed, there is short lifespan, and mainly it affects the cardiovascular system with hypertension, left ventricular hypertrophy, cardiomyopathy, and arrhythmias. Presentations of acromegaly. Symptoms due to tumor size normally are presented with headaches, nausea, and importantly, visual field defects. Symptoms are due to associated hyperprolactinemia also, right? Because one it's producing the other one. If the tumor interrupts, obviously, the tonic inhibition of prolactin, right? So some of the symptoms associated with hyperprolactinemia are galactorrhea and amenorrhea. Remember, galactorrhea, right, is production of milk outside of the pregnancy by the breast, and it can happen both in men and in women. Amenorrhea means lack of the period and menstrual cycles, and it can be primary or secondary amenorrhea. Hypopituitarism, obviously, if you have a tumor that is growing in the pituitary and it extends to the pituitary gland and it breaks the axis with the hypothalamus, it can lead to decreased secretion of anterior pituitary hormones. And this can lead to one single hormone deficiency, multiple single hormone deficiency, all the way to panhypopituitarism. And very important, what happens if the tumor grows too large? There is compression of the pituitary stalk. And why is important the pituitary stalk? Because it connects with the posterior pituitary. And the posterior pituitary has oxytocin and arginine vasopressin or antidiuretic hormone. So the clinical symptoms and signs and diagnosis are normally changes in facial feature, enlargement of hands and feet, headaches, sweating, joint pain, and most importantly, right, it's tall stature. So if there is a very, very big spur on growth during childhood, this leads to gigantism, and that can start very early, pre-pubertal. So there is an elevated levels of IGF-1, and obviously the test that is done is oral glucose tolerance. We will cover this part in the glucose metabolism and in the lecture of diabetes. And growth hormone not suppressed by glucose intake. And also, what you can be done is a pituitary MRI where you see a tumor, right? And then obviously there's going to be surgery. So again, what we know, growth hormone releasing hormone acts in the pituitary gland to produce growth hormone, which acts in IGF-1, and IGF-1 is released from the liver and acts in the bone and in the growth and in lots of different organs. Now, lots of you, I think, that will be clinicians, right? And you are studying a medical degree. So just to show you the comorbidities and how difficult is the treatment of and diagnosis of this condition, because these tumors grow very, very, very slow. So they present slowly with different doctors, right? So I have put here different presentations: headache, changes in hands, lack of energy, hypertension, general unwellness. And this is diagnosed by a general practitioner. But also, they have problems with hands, feet, back pain, joint, carpal syndrome, headache, which is seen by an orthopedist. Also, they have headache, visual impairment, depression, numbness, and carpal tunnel syndrome. So this is seen by a neurologist by 20%, 27% of the cases. Obviously, it's also diagnosed by endocrinologists because they are suspected acromegaly in 5.5% of the cases. There is a hormone investigation, and then obviously there is linked to diabetes, thyroid disease, and other diagnoses. Also by general physicians, by ophthalmologists, because they have disturbance of the vision, defective vision, and headache and photosensitivity. By dentists, because there is a massive growth of the jaw, changes of bite, occlusion, enlargement of interdental space, damage of the teeth, and malposition of the teeth. By a gynecologist, because too much excess of growth hormone, as we will study in the reproduction, it actually produces hypogonadotrophic hypogonadism or infertility. So too much hormone makes you grow very tall, but it produces infertility. By a cardiologist, excess of growth hormone produces hyperplasia of the heart, hypertension, and heart disease. That's why all these patients have very short life expectancy. Abnormal hair, skin changes, acne, warts, carpal syndrome, and brain tumors in some cases by the neurosurgeon and by psychiatrists because they have depression and anxiety. And also, and finally, one of the people that should actually realize are jewelry. Because the hands grow so fast, the rings cannot fit anymore. So if you have any of these presentations, physicians should be able to detect acromegalic signs. So also this slide reflects very, very well all the comorbidities of having tumors in the growth hormone. And this is a picture of an MRI of a giant, right? Was published in the Lancet in 1980s. And what you can see is that the epiphyses have been sutured, and you can see here all the different nails because they have high osteoporosis, and these guys do not stop growing. They carry on growing, growing, growing. So they have open epiphyses since child, There is massive delayed puberty. The tumor destroys all the LH and FSH cells. This is the problem, right? So if you look at the pituitary as an organ, apologies, the tumor will take over all the other cells. So then there is going to be hypopituitarism on LH and FSH, and obviously, in turn, this will produce infertility, right? And also there is an increase in prolactin, which inhibits LH and FSH. And in this case, this patient, Carl Bryan, at the age of 22 was still growing, and they can grow all the way to more than 2.5 meters. The problem is untreated pituitary giants die at 20 years old if they are not treated, right? One of the problems is that growing very tall, sometimes the families don't take their patients into the clinic because they think that their kid is going to be very tall, and being very tall is a good thing in our societies. Everyone wants to be taller, but often being too tall means that there is a growth hormone pituitary tumor in the brain. This is two hands, hand from a acromegalic patient versus a non-normal. You can see they have massive hands. The hands keep growing. And this is an MRI of a patient with acromegaly. They have severe osteoporosis, so you can see that has to put all this iron to maintain the posture. Otherwise, the bones are not strong enough to maintain the posture. And you can see the pragmatism of the mandible, and this produces very severe defects. So we need to be able to prevent all these defects on acromegaly. Here in this slide, I show you all the organs that are affected by growth hormone in acromegalic patients or excess of growth hormone. It affects the heart, and it produces cardiomegaly, expansion, massive expansion of the heart, and this obviously leads to death. Hyperostosis and thoracic vertebra, abnormal glucose tolerance secondary to insulin resistance. We will study this when we study the insulin pathway and the diabetes in this module. Increase in the size of the hands, growth of the long bones in children. It produces degenerative arthritis, thickening skin, and hypertrophy of excessive sweat glands, so that is excessive. Also in the face, acromegalic features with growth nose, pragmatism of the mandible, and at the level of the gonads, hypogonadism and infertility. So I hope I am convincing you of how important are these tumors of, growth hormone secreting. Although they do not metastasize, they lead to very poor, short life, and multiple comorbidities, which are needed to be seen by multiple doctors, and the cost to the national health system and the burden to their families is very considerable. So there are obviously, every time that there is a change on growth hormone production or any other hormone, there is a metabolic features, right? So there is impaired fasting glucose, impaired glucose tolerance, diabetes mellitus, insulin resistance, reduced total cholesterol, and increased triacylglycerides. The investigations normally are done is history and examination. There is a retrospective photograph, important. Here, I'm putting a photograph. the before and after. Before and after, right? You can see here a patient before had the pituitary tumor, and then after, slowly, how this patient becomes acromegalic features, growth of the nose, growth of the mandible, growth of the ear. So look after, this person, right? So when you are in the clinic, you will be able to see, okay, are you a acromegalic patient? Give me a picture of when you were young, right? And you will see these features happening. Also, there are obviously clinical features, comorbidities associated to it, respiratory disease, diabetes, malignancy, arthritis. Biochemical tests can be done, oral glucose tolerance test, insulin-like growth factor. So obviously, if you measure insulin growth factor, you're going to see increase, obviously, in IGF and also increase in growth hormone. And obviously, evaluation of overall pituitary function. Also, there is MRI, so there is a structural MRI to see the tumors, and visual field testing. Now, one of the reasons we don't look at the growth hormone, this is in a normal patient. Remember, someone asked me, what does it mean episode or pulsatile? What you can see in the normal is that there is episodes. You can see a big peak of growth hormone secretion. But in acromegaly, it's all the time high, right? And it lacks the peak, and the second peak is all the time high. So there are no single point hormone measurements for this to be informative, right? Because also in normal patients can be high, as high as acromegaly, but then obviously is all the time high. So what we perform in the clinic is the glucose tolerance test. Growth hormone levels, or at least partly, right, regulate blood glucose levels. Increasing blood glucose should be suppress growth hormone secretion. So if you have increased glucose, right, that should inhibit growth hormone production. Decrease, on the other hand, of glucose should increase growth hormone secretion. So based on this is just a growth chart of normal growth of a patient that has been restored with growth hormone, right? So the test of glucose tolerance, right, is basically done 75 grams of oral glucose. You don't need to know the measures. You just need to know that the glucose tolerance test is performed, right? And basically there is rapid suppression of growth hormone secretion to normal levels, okay? So, but however, not in acromegaly. So there is, this is what is called glucose tolerant test, right? So if you have more glucose, right, you should suppress growth hormone secretion. But if there is a pituitary tumor, the growth hormone will continue being activated and they will have high level. Insulin tolerant test, right? So there is a stimulation of growth hormone secretion and partial deficiency and severe growth hormone deficiency. Also, there is amino acid, let me go back to the slide. Amino acid infusion. But basically, what you need to know is the glucose tolerant test. And this is a very nice representation of the glucose tolerant test in growth hormone axis. We have two growth hormone level, right? You give glucose, right? And glucose should inhibit the production of growth hormone, right? This is the normal regulation. However, in acromegaly, after glucose, the growth hormone continues being elevated. And this is after 30 minutes. So there is an overnight fasting without eating fixed dose of glucose, and then you measure the growth hormone. I think that this slide is the easiest to understand for you guys, right? So you give glucose to the patient, then after 30 minutes, if you give a very high dose of glucose, growth hormone should go down. However, if it's an acromegalic patient, growth hormone should will still be high. Why? Because there is the growth hormone secreted by the tumor. If growth hormone is detectable after 60 minutes, this suggests acromegaly or excess of secretion of growth hormone. There can be also single measure of IGF. Remember that growth hormone, right, signals to the liver to produce IGF level, and if there is increase in IGF-1, also this is telling us the diagnosis of acromegaly. So all the important part take-home message is glucose regulates also growth hormone production. Glucose tolerant test, it's done after overnight fasting. Infusion of glucose, then in the normal patient goes down, but in the acromegaly, you measure the growth hormone and it's still high, right? And then there is a measure of growth hormone if there is excess at 60 minutes that suggests of acromegaly, and then there is a single measure of IGF-1, and if it's elevated, it suggests and confirms diagnosis of acromegaly. So diagnostic criteria, lack of growth hormone suppression during oral glucose tolerant test, and elevated IGF-1 level. So there are managements of acromegaly and there are advantage and disadvantage. We're just gonna mention few. Again, you don't need to know the ins and outs. You will come up to it in more detail as you advance in your medical degree or depending on the specialty. But basically, there is more common treatment for a pituitary adenoma, transsphenoidal surgery, right? This will take out the tumor and then obviously stop the oversecretion. This has rapid effect, can restore the vision of optic nerves progression, maybe a curative and complemented resection. Also, you can use somatostatin analog drugs. You need to think why. Why is somatostatin important? What was somatostatin doing? Do you remember the lecture that we did before? Somatostatin is inhibitory. There are two inhibitories, right? Hormones produced by the hypothalamus: dopamine and somatostatin. Somatostatin inhibits TSH and growth hormone. Meyer's ring-like extracellular tumors decrease on growth hormone in 60% of patients responsive, and also some radiotherapy, bearing in mind that radiotherapy has its side effects. Obviously, as all the treatment is not perfect and it has disadvantages, and the disadvantages are explained here, right? Invasive and require general anesthesia, right? For transsphenoidal surgery, right? Obviously, it's aggressive surgery. Non-curative for large extracellular tumors. May cause hypopituitarism by damage to other cell types. Okay, if there is like in complete resection of the tumor, if they take out the tumor because it's too big, but they take out the interior pituitary, then you end up with panhypopituitarism or non-pituitary function at all. Okay, then are also side effects, for example, gastrointestinal, and then also there are other side effects such as unlikely to be curative or continuous therapy needed. So means that, for example, if you are applying a drug like somatostatin, it does have side effects, right? So, for example, one of the things of the somatostatin analog is that it needs monthly intramuscular injection, which is the most common, but is also quite painful. But it requires going into the clinic and injections every month. So just to finish the lecture, and today obviously the lecture is a little bit longer, we're gonna just touch down on disorders of the antidiuretic hormone secretion. If you remember from the lecture yesterday, the antidiuretic hormone or arginine vasopressin or AVP, it's secreted from the hypothalamus and goes into the posterior pituitary. It's secreted into the circulation and it acts in the kidney tubules to regulate osmolality of the blood, right? Through aquaporins, right? So it produces the reabsorption of water. What happens if there are defects on this one is that we can get dehydrated and die, right? So the disorders of ADH production, they can be either overproduction, excess, or underproduction, deficit. Overproduction is syndrome of inappropriate antidiuretic hormone hypersecretion, or also known as SIADH. Main symptoms: decrease in urine volume due to increased renal water reabsorption, leading to decrease in plasma sodium concentration, or also known as hyponatremia. Causes are ectopic ADH secretion, and it's linked to lung cancer, brain injury, Guillain-Barré, hypothyroidism, porphyria, and drugs. So there are multiple causes. And the test normally is plasma and urine osmolality, and also plasma and urine electrolytes. What happens if there is underproduction of ADH or arginine vasopressin? Remember that it has two names, right? Antidiuretic hormone, ADH, or arginine vasopressin. It produces diabetes insipidus, right? And the main symptoms are increase in urine volume, polyuria, or polydipsia, right? And the causes can be cranial or neurogenic, can be genetics, for example, that can be also associated to other syndromes, injury, infection, and also certain drug side effects. Also nephrogenic, which can be genetic, right? Infections and also drugs. And the test is water deprivation test to look at the urine, okay? Very important conditions because this needs to be treated very, very soon because if the osmolarity of the water is not regulated, it can lead to death. This is the normally diagnostics, right, of the concentration of the osmolality in the different diabetes insipidus and the SIADH. However, you don't need to know exactly this. You just need to know that in some cases it's down and that there is measured in the plasma, in the urine, and with the urine output and the sodium, right? And that you don't need, unless you do all these tests, you don't need to know it. What is important to know is this one here and the main, obviously, causes and what it leads to, okay? So obviously there is the management of ADH production disorders, both for the syndromes of increased ADH production, but also the lack and diabetes insipidus, right? And they can be treated by either fluid restriction or different drugs, as you can see here. In the case of diabetes insipidus, is treated by vasopressin analogs, the arginine vasopressin, and desmopressin. There are several treatments, drugs that work as complementing the lack of the vasopressin. So with this, I think we have covered the main important diseases of some of the most known diseases of the pituitary gland. I hope that I have convinced you that obviously those are severe conditions. We have not gone through all of them. There are so many more, like hypophysitis and autoimmune disease, and a lot more that you will be studying in the future. But we touch just the most known or important with the two axes, prolactin and growth hormone. You're going to be studying pituitary disorders also in the other aspects of the HP adrenal axis, HP gonadal axis, and also HP thyroid axis starting on Monday. So I would like you to just cover what we have done in these lectures, right? We have covered some diseases of the anterior pituitary, the most important at the moment for your biomedical and clinical degree, right? So basically we've covered the anterior pituitary adenomas, treatment of the pituitary adenomas. We have gone into two main conditions. Remember that we will go into more, like fertility is a lot more complicated. But today we've covered two, hyperprolactinemia and prolactinomas. We covered the etiology, presentation, investigation, and management. Acromegaly, epidemiology, etiology, presentation, investigations, and management. And then two functions of either increase in ADH production or decrease in antidiuretic hormone production, diabetes insipidus. So let's see, what do you need to know, because this is a lot of information, but at least you should know some different diseases of the pituitary gland, the etiology and presentation, right? What is hyperprolactinemia and prolactinomia and prolactinomas, tumors, and the etiology and presentation of growth hormone tumors leading to acromegaly and gigantism. So this is further reading that you will see. And then, as I told you before, right, there are some questions. I don't think today we have time to cover them, but I will put that in the presentation, and in your free time, this will be uploaded in the QM Plus. You can use it for your own study, right? So, I mean, we can read a couple of them, but I'm sure you can do it after also, because I'm aware about the time. So endocrinopathies are classified as primary, secondary, or tertiary. Which organ is dysfunctional if the endocrine disorder as a secondary disease? Adrenal, pancreas, hypothalamus, pituitary, or none of the above? Which of the following hormones inhibits prolactin release from the lactotrophs? We should know that already. Thyroid releasing hormone, vasoactive intestinal peptide, dopamine, serotonin, or oxytocin. We already covered that in another lecture. Which of the following class of drugs cause hyperprolactinemia? EC inhibitor, anticoagulants, dopamine receptor agonists, dopamine receptors antagonists, or insulin. Excessive vasopressin secretion will lead to diabetes insipidus, type 1 diabetes, type 2 diabetes, or SIADH, or dehydration. Hypersecretion of growth or hormone in prepubertal children can cause, so excess of growth hormone in prepubescent, before puberty, whilst you are still growth, acromegaly, hyperprolactinemia, dwarfism, or gigantism. How is microadenoma classified? More than 1 centimeter, more than 4 centimeters, less than 1 centimeter, less than 4 centimeters, or less than 10 centimeters. Which is the following is not a function of the growth hormone? Increase protein synthesis, decrease tissue glucose outtake, promote lipolysis, stimulate production of release of IGF in the liver, or promote fetal growth. We touched this also in one of the lectures. It doesn't matter, guys, if you don't know. The questions and the right answer will be uploaded in QM+. So if you get it wrong, that means that you need to revise that part. It's not a problem, right? This is self-assessment for you to see if you have understood the lecture. Which of the following is not a clinical feature of prolactinoma? Amenorrhea, amonorrhagia, galactorrhea, loss of libido, or infertility? In gigantism and acromegaly, a patient will appear with prognatism as clinical feature. What is prognatism? Excessive hair, buffalo hump, enlarged hands and feet, frontal bossing and protruding mandible, or enlarged tongue. And with this, I think what we're going to do is to stop sharing and then finish the lecture, and hope you have all enjoyed the lecture. And as you can see, it's getting a little bit more complicated, but you will be able to relate every single hormone to a specific disease, right? And by the end of the module, you will cover all the metabolic and endocrine conditions in the different axes. Okay, guys, thank you very much for attending, and I will talk to you in the next week. Okay, thank you very much.